خلص داني روحي لهنيك يطلعوا لايف.
رايحة
بس تطلع لايف قولي لي.
ما هو أنا واقفة هون هيك بلاش كأنك. That's it.
اوكي
يا الله.
خلص داني روحي لهنيك يطلعوا لايف. بس تبتدي تطلع صوتك. Okay, I think I am live now, right? Okay, I think I am live now, right? Okay, I think I am live now, right? Okay, we are live. Can you see the screen? Can you just give me some comments if the audio is working, if you can hear me, if you can see my slides? Everything is clear? Okay, I think everything is good. Can you hear me? It's okay, the voice. Can you hear the voice? Okay, so I think everything is okay now. The voice is clear. My slide is showing on the screen, and everything looks perfect. First of all, I am very sorry for the delay. We have very big technical problems. The Zoom program was down. The system of the Zoom program connecting to the Facebook was down. We tried many times. We changed the program. We downloaded another one. And now we learned how to use the new program just in 1 hour. So I am really sorry for the delay. Thanks, AT, for your support. Thanks for Evie, Lily, Mickey, Elfie, all of you. Thank you very much. It's my pleasure to be here today, finally, after fighting with some connection problems, technical errors. Thank you very much again. I hope that everyone today with us live will enjoy the presentation. We will start to discuss together about broken files removal and how to manage broken files in general. And also in specific, I will talk about, or I will discuss with you, how to remove broken files with loop technique, which is the BTR device, the broken tool remover device. And also, we will discuss together some general ideas about broken files. I hope that you can hear me again clearly. If yes, please give me confirmation, Ivy or anyone on the live stream, because I am afraid that I am talking alone, like what happened just 1 minute before. Okay, so if we are talking about broken files, we are speaking about a very interested or very interesting topic. Every one of us is breaking a files every day in his clinic. No one is able to do root canal treatment every day without breaking a file. So it's a normal thing, and we have to discuss, or we have to learn how to manage the situation with the broken files. So about theories. If today I will talk about theories, you will be bored and you will close the live and go to check your Facebook homepage again. So I will not talk about theory. You can read about theories on your textbook. You can Google it. You can see what are the causes of separation, cyclic fatigue, torsional stress, blah, blah, blah. You can check what do we mean by cyclic fatigue, torsional stress. You can know more about it. And just I want to say that the broken file is a really difficult situation for the clinician, because the frequency of separation or the frequency of broken files is really high, because we have about 1.8 to 8.2%, which is not a small percentage. That's why we have to be careful and we have to know the management. For sure, you can see that most of the broken files are present in the molars, because we have, and especially in the mesial root of the molars, in upper molars or in lower molars. So the mesial root has a slight curve to the distal area, and the internal anatomy is a little bit curved. So 77% to 89% of all the cases are in the mesial root of the molars. So how to prevent the separation? For sure, with the proper glide path, with the proper anatomy analysis before starting your root canal treatment. So before opening your axis, you have to spend 10 seconds at least, 20 seconds at least, to check the root canal anatomy, to check if there is a slight curve or severe curvature, to check properly what is your sequence for shaping. And in this way, you can prevent the broken file situation. So as I told you, I will not go deeply in the theories. I will go directly to the management, because I know most of you, or maybe all of you, are waiting the management of the broken files, how to manage the situation. You are waiting to see how can we manage the broken files at the apex or at the middle or the coronal third. And in this, as you can see here, the figure, you can check that in the area of the green color, we have coronal to the middle third of the root. This is not only the coronal third, coronal to the middle third of the root. In this area, the fractured instrument should be removed. No place for bypass here. In this area, we have to remove the broken file, because broken file removal in this area is easy. We have sufficient dentine thickness. We have to clean and shape our root canal properly without any broken file in this area. So in this area, the green area, we should remove the broken file. While in the blue area, when the broken file is located middle to apical third, this is not only middle third, this is middle to apical third, we can think about bypassing in this area. So in the blue area, we can think a little bit about bypassing if the broken file is not visible. While if the broken file was in the red area or in the apical third, or the last 2 to 3 millimeters of the apical third, we can think here to bypass only, because we have risk to remove more dentine, and we have risk to do some maybe aggressive preparation or aggressive removal for dentine. And sometimes we have another choices, and we will discuss more about it later. So for management, if we have like this broken file in the mesiobuccal root, we have a short broken file, 1, 2, or 3 millimeters. And the broken file is located, as you can see, in a slight curvature, slightly curved canal. So under microscope, I will not be able to see this broken file directly. I have to enlarge the canal to do a straight line access to reach the broken file, and in such situations, I will remove too much dentine. That's why when we have a short broken file, 1, 2, or maybe 2.5 to 3 millimeters, and it's located deep in the canal and after the curve or beyond the curve, so in such situations, the best option is to bypass. The best option here is bypassing. But the question is, how to bypass? here is the real question: how to bypass? This is very important topic, which is the bypassing, but we need to know that not all broken files are bypassed. This is the real situation, the clinical situation with your patient. You try to bypass, then nothing happened. Why? Because you feel that you are just knocking a wall or there is a blockage. You did everything. You pre-bent your K files. You use some finders, definders, step file, C file, B, C. I don't know, but at the end there is no bypassing. In this situation, we have to go back to the removal. But sometimes we can succeed with the bypassing, and we have to continue bypassing because it's in a curved canal and it will be more conservative. So this is very important thing to know. The first step of bypassing is to pre-bend your K file. So we have two kinds of curved or pre-curved files. First one is you can see here the first file, the curved one, and the second one is the kinked one. The difference between both is that the curved one has a gradual curve, while the kinked one has a sharp curve. So which one we have to use during our bypassing procedure? Any pre-curved file or any pre-bending file? No. We have to use the gradual curved one. Why? Because with the kinked one, we have, as shown here and as you can see clearly, we have two surfaces. We have straight one and we have severely curved one. And at the connecting point between both, we have here a weak point. That's why when you bypass using kinked K files or kinked curved K files, when you bypass and start to do the watch winding motion to complete the bypassing, you will have a fracture here because this point is very weak. So you have a secondary fracture, and now you have two broken files behind each other. And then you try to bypass again the two broken files, and then with the same kinked file, you will have the three broken files together. So be careful. The most important thing when you are bypassing a broken file is to do the proper pre-bending. And in such situations, we have to use the endoplier. Most of the time, when you are doing the pre-bending with your fingers, you are doing the kinked one. That's why you do the kinked pre-curve and you try to go inside, and sometimes you feel that you are just pushing or just knocking the walls. There is no any catch because we have a sharp curve in a kinked K file. While if you are using the plier, here you can pre-curve a gradual curve because you are using endoplier or orthoplier, for example. You can do the gradual curve for the first 2 millimeters, and in this way you can negotiate the space around the broken file with some watch winding motion, as we'll see later. So this is the first step. For the second step, you have to try to find a catch. With watch winding motion, you pre-curved your K file. Maybe you can use short 21 K files if you have a long root and the broken file is deep. Then you try to find a catch. With the watch winding motion, 30 degree to the right, 30 degree to the left, backward, forward, backward. Watch winding motion, you can feel that the K file is catching. And if you leave it inside the canal, you will feel it stuck. If you just move it a little bit, it will not go out. So that means you have catched a space around the broken file. Okay, very nice. Then what is the next step? Go with 15, 20, 25 K file. No, don't do this. Try to do what you are seeing now in the video. This is the K file, pre-curved. Now I have the catch. Look, watch winding motion, up and down, watch winding. Now I have the catch. If you go out, it's a little bit difficult to catch the space again. You can see here now I am touching the broken file. I couldn't go again to the space, but with some watch winding motion you can go again to the space. Now I am catching the space, watch winding up, watch winding up. Now no, I am again out, again I am in. So this is very difficult. It's very difficult. My suggestion is to do this movement. Look, now you put your finger on the cusp, and with the thumb you can go up and down, up and down. This is very, I don't know what to name this movement. Maybe we can name it as a bypass cusp thumb or cusp finger supporting movement. Now you can see I can go out and then go back easily, because now I have a good space around the broken file. So put your K file inside, pre-care, irrigate, and then give support to the K file when you are supporting your finger on the cusp tip, and then with the thumb go up and down. I will repeat it again now. I choose a stiffer file, and now you can find the catch easily. You can see here clearly the catch. So I reach it to the working length now, and the broken file is bypassed, and this is the movement. Put your finger on the cusp and try to go up and down. Now you can see here. Okay. Because if you go out, it will be difficult to go in again. So stay in and do the brushing up and down motion when you are supporting your finger with the cusp tip of the tooth. This is very important. After that, you have 10K file loose at the working length. With the correct movement, you will have 10K file loose at the working length. Irrigate again, use glide, and after that repeat the same movement with a pre-curved or pre-bent 15 and 20K files. Okay, so the same curvature, the same gradual curve in the first 2 millimeters of the K files, pre-bend again, and do the same sequence with 15 and with 20. Why I don't prefer to go to 25? I prefer to stay only on 20, because with 25 you will go with a big step from 20 to 25, and this big step with the broken file inside, maybe you are doing some zipping for the canal, or you are doing some if we want to say a false path or false canal, or just you are changing the portal of the exit, because K files are stiff, they are not like nickel titanium, and I prefer to stop at 20 K file. After that, you can use your rotary, and specifically heat treated rotary files. My protocol for bypassing is to use 1704, because you have already 2002 reaching the working length. So after that you will use 1704, you are just enlarging the taper. You have 2002 now reaching to the working length, bypassing the broken file. Then you will go with 17, and that's why it's not a problem. Just we are increasing the taper from 2002 to 1704. And after that, clean again, put again your 10K file and 15K file, check if your bath is still reaching the working length, go with the next rotary file 2004. Now you are just enlarging the taper again. So don't be afraid that you will break a rotary file at the apex, because the apex is already 20 and you are just enlarging the taper. But you have to be careful. Don't keep your rotary file behind the broken file. Just do 1, 2, 3 strokes and go out. 1, 2, 3 seconds and go out. And you can use the tactile control activation technique, which is invented by Antonis Canutis. Thanks for him for this great technique for bypassing broken files with or for shaping curved canal. Essentially, he invented this technique to shape the curved canal, but we can use it when we are doing the shaping with rotary files during the bypassing. So you can put your, you can pre-curve your rotary file, you can put it inside, and then you can activate the rotary, and then you will start shaping. So 1, 2, 3 seconds and go out, irrigate again, and go to the next file 2504 until you reach to this size. You are now ready to obturate. You put your master cone 2504 and try to do the obturation. So I think now we are nearly maybe considering the broken files in the apical area. Now we can use the protocol of bypassing. But as I told you, sometimes we couldn't bypass a broken file. We couldn't do it. Let's be honest together. Not all the broken files are able to be bypassed. Let's be honest. And when you are trying to bypass, and when you insist on bypassing a broken file, and then you have a block, or you feel that you are just knocking a wall, and you insist to bypass it, and you start to push more your K files, unfortunately, you are now trying to drill your own path and drill your own false canal just to reach to any area in the apical third, and then do some shifting x-rays, and it will be okay. You will tell the patient that, look, my gutta perca, my white line is reaching to the apical area, and that's it, I bypassed the broken file. But actually you deviated the canal, and you did a false canal, and the main anatomy is not negotiated. So sometimes we have to remove. Let me summarize again the bypass attempts. If you tried the bypass and you have a successful bypass, it's okay, thank you very much. But when you have unsuccessful bypass, you have to assess the risk. We have to do risk assessment. If the broken file in the apical third, beyond the curve, not visible, thin roots, we have no tools, we have no experience, please don't try to remove it, because we have a high risk for removal. While if we have no symptoms, you can just obturate to the fragment level and keep it there with follow-up. And don't forget that we have a surgery option. While if we have symptoms, you can go to the apical surgery. So make risk assessment. If the broken file in the apical area, beyond the curve, not visible, thin roots, no tools, no microscope, no ultrasonics, no experience with removing broken files very deep inside the canal, try not to remove. And if there is no symptoms, try to obturate to the fragment, or if you have a symptoms, go to the apical surgery, or just refer the case to the specialist one. But if the broken file in the middle or coronal third, and maybe it's at the curve, it's visible, we have sufficient dentine, we have tools, we have experience to remove broken files, so we have low risk to removal, low risk for removal attempts, then if we have successful removal, it's okay, thank you very much. If you don't have successful removal, we have to go back to the symptoms. If you have symptoms, we will go to the apical surgeries. If you don't have symptoms, so maybe you can obturate up to the fragment and then do the recall, and with recall everything will be clear if you go to surgery again or not. Let's have an example. Look at this broken file. We have a very big broken file exceeding the apex. Here, no place to bypass. We have to remove. So in such situation, we have only one choice. The choice is the removal. And please don't forget that the rate of successful fragment removal ranging from 45% to 95%. So we are able to remove broken files in 95% of the cases. While for bypass, it's only 9 to 47%. So endodontists or specialists or clinicians who are dealing with broken files feels that they can remove more than than they can bypass. And actually, I feel like that. I can remove more than I can bypass. That's why the percentage rate is higher in removal. And this is not my opinion. We have studies published, and you can see the references there. We have studies published, and these percentages are according to the literature. So the third management now, if we have such a broken file, is to try to bypass. If you couldn't bypass, try to remove. If you couldn't remove, what you will do? In such case, I tried to bypass, not successful. Tried to see the broken file. It was invisible because we have a slide curve. The internal anatomy is curved. It's not necessary to see only in the X-ray that I have a straight canal, but maybe the internal anatomy is curved to the mesial or distal, buccal or lingual direction. But on the X-ray, the root is straight, is okay, but the internal anatomy is curved. So in this case, I couldn't see the broken file. I do the pre-flaring, I did everything, but couldn't see it. So I clean too much, I irrigate, I activate with ultrasonics, then I did my obturation. I will obturate in such cases and see. This case is still fresh. I will make the recall maybe after 2 months, and then I will decide. We have to go to apical surgery or we have improvement in the apical area. Because as I show you here, we have obturated the root canal and we have a slight sealer buff outside, which means that maybe I cleaned all the space around the broken file and I reached to the apical area. So we have to obturate and see. This is the third management of the broken file. Let's go back to the main topic of our lecture today, which is the removal. We will talk about broken file removal, and when we are saying removing a broken file or removal of broken files, we are dealing with usually two large techniques or two maybe categories. One of them is the ultrasonic. So ultrasonic is one of the techniques to remove a broken file, and the other technique is the grasping technique. So we have two general techniques to remove a broken file. One of them is the ultrasonic and the other one is the grasping. And in a grasping technique, we have two different techniques. We have loop technique and we have a tube technique. So for example, we have Zumax kit, we have ERS, IRS, Maserran. They are designed as a tube technique, just like a tube, metal tube, and inside this metal tube we have a metal wedge. Okay? And the other grasping technique is the loop technique, like PTR, broken tool removal, like Endocowboy, like Yushi loop. And also on ERS we have ERS loop, but I think the manufacturer stopped producing the ERS loop and focused mainly on the BTR. So BTR, Endocowboy, Yushi loop are loop technique, grasping loop technique, and other devices are tube grasping or wedging tube grasping technique. So what is the main problem of wedging tubes or the tube technique? The main problem that the first kit designed for such technique was the Maserran kit many years ago, and this kit, the main problem of this kit was that it is very aggressive because it used the triffin bears. You have to drill all the way until you reach to the apical to the broken file, and then you have to enlarge around the broken file and drill or triffin around the broken file to expose 1 or 2 millimeters. Then you have to put again the extractor. This one, as you can see in the middle, the yellow one with IRS, which is the updated version of Maserran kit. And then you have to put the metal wedge inside the tube to press on the 2 exposed millimeters of the broken file and then try to pull all together. So it's a little bit sensitive technically and aggressive in my opinion, because we have to use triffin bears, and triffin bears are most of the time very aggressive. if you have a broken file in the middle third or middle to apical third, this technique is very aggressive. Okay, so the problem now is that all the new devices use tube technique. They are using the same concept of Maserran kit. They are producing triffin bears and they are producing tubes, and inside the tubes we have wedge with some button to activate the wedge. That's it. So it's very strange to stay at the same concept. Look at this case, for example. I have a broken file exceeding the apex. This was F2 broken file, very big mass of metal. And here I have to remove it because I have symptoms. The patient has severe pain. And when I try with ultrasonics, it doesn't work because the broken file is stuck outside. It's very big. The ultrasonic will not do anything. It will not do anything because you are just removing metal from the broken file because you are touching the broken file with your ultrasonic tip and you are removing dentine around it, but the broken file will stay stable there. That's why we need a grasping technique. So with longer broken files and bigger broken files, grasping technique is better than ultrasonic. So in such case, I need a grasping technique. So I tried the loop device. I tried a loop device, but I was not successful because I used two devices and I broke them because the wire was not strong. So I shifted to another grasping technique which utilized triffin bears. I triffined the root all the way until we reach to the broken file. Then I put the extractor, the tube, and the wedge, activate the wedge and go out, and then I remove it. It's okay. But I destroyed the root. Completely destroyed. You can see very aggressive. Very aggressive. Why? Because I have to reach to the broken file with the extractor. And to put the extractor inside, I have to drill all the way with the triffin bears. The triffin bear will open the rod or will open the canal to the extractor. So you have to use it. Otherwise, you will not be able to put the extractor inside, and that's why you have to remove too much dentine. That's why this is the same concept of Maserran kit. So why to remove coronal dentine when I have only a broken file maybe in the middle area and I have a great space around the broken file? I need only to remove some dentine here in this area, as you can see the red arrows, and then catch it and remove it. So I need only to remove dentine around the broken file. While if you will use a tube technique, you have to remove all the dentine from the orifice level till you reach to the broken file. So here is the new concept we will talk about later to preserve more dentine. Okay, the new concept is the loop technique, but which loop technique? The grasping loop technique usually used when the broken file is long. When you have 3.5 to 4 millimeters broken file, you can use a grasping technique. If you have the broken file at the orifice level, it's okay, you can use tube technique. But if you have middle to apical area broken file, tube technique is very aggressive. You have to use loop technique because the loop reaching or the needle that contains the loop will reach the broken file easily. You don't need to use triffin bears, and we will discuss more about that later. Also, when you are using loop technique, you have to use the ultrasonics. And with short broken files, also you have to use the ultrasonic to remove it. Because when you have a broken file 1, 2, 3 millimeters and you couldn't bypass, you have to remove. For short broken file, it's enough only to use ultrasonics. On the inner wall, as Yoshi suggests some years ago, the old concept to triffin around all the broken file is not used again. You don't need to do 360 degrees trifling around the broken file with the ultrasonic. You need only to prepare on the inner wall with the ultrasonic tips, and then you activate your irrigant in that area so the broken file will go out. And for such procedure, you can use the Ultra X. But you have to know that Ultra X with the gold tip is a wireless device and it contains only two power setting. So sometimes we need more power setting to work more on the inner wall and work more to push the broken file to the coronal area. And sometimes we need to raise a little bit the power and to activate with high setting power. So maybe you can use the device. But the Ultra X working very good to remove some denting around the broken file. But it will not work on the broken file directly because we need a little bit more power. For activation, I use this device, and honestly I cannot go back to the other activation devices because I found it really the best. Let's go now to the loop technique, which is the BTR. We have here the BTR pen, as you can see, and we have the needle. Inside the needle, we have the loop, and we have the calibrator. So, why to choose the BTR loop, not any another loop device, for example? Why to work only with, if you want to do a loop technique, why to choose the BTR device? As I said, we have many devices that utilize the loop technique, but for me, why I choose BTR? Because it's very important for me the strength of the wire. The strength of the wire is very important because I need to remove a broken file that it is stuck inside the root canal. So I need something really hard to catch it and push it out. And to do this with the wire, we need a really strong wire. So this is the difference between BTR and other loop devices. The difference is in the lifting capacity. With the 0.3 size needle, the yellow one, we have inside 0.076, which means 0.07 millimeter wire size. So the gauge of the needle is 0.3, while the wire inside is 0.07, which means very thin wire. Very, very thin wire. And this wire can lift about 1.5 kilograms. While the 0.4 millimeter gauge needle contain about 0.85 millimeters wire size. So it's a little bit thicker or bigger, the wire inside the needle, and the needle is also bigger, but the lifting capacity is also higher, 2 kilograms. For the third size, we have 0.5 millimeters for the needle size, and the wire inside is 0.1. So this needle with this wire can lift about 2.3 kilograms, and we have tested that. We have tested that, as you can see here. I will scroll a little bit to show you the test. You can see here the BTR. Sorry. I'll show you again. I'm sorry. Okay, now it's good. So as I said, the lifting capacity is different because the wire is strong. The wire is nickel titanium, nitinol, heat treated nitinol, and the lifting capacity is really high. You can press on the loop, you can push it inside the root canal, and that's why we can remove stuck broken files without making them dancing. Other loop devices, you should use it only when you have a dancing broken file or moving broken files. You can see here the test. The 0.3, 0.4, and 0.5 can lift about 1.5 to 2.3 kilograms. So this is a strong wire, and we need strong wires to deal with the broken files. That's why many people they like the the tube technique, because with the tube technique you can pull hardly. It is strong, but if you have a strong wire, you can shift your cases to the loop technique, as what I did. So how to set up the BTR bin? Now we have to know how to set up the bin, and after setting up the bin, I will show you clinical cases how to use it, and I will show you the step-by-step technique how to use it. So this is the BTR bin. Here we have the front handle, and inside the front handle we have the slot here, the metal slot. Inside this metal slot, you can see here we have a space to put our metal notch. I will discuss about it later. And also we have here the back handle, or the grip node, this one for closing the loop. Okay, so we have front handle and back handle. The front handle contains the metal slot, and the back handle contains the grip node. So in this area, when you close the grip, when you close the back handle or you close the grip knob, the metal slot here will go inside. This is very important to try first before putting before attaching the needle. Try if your grip knob is working correctly, so the metal slot here will go inside. Then bring your needle and put the metal notch, this one, you can see it at the end of the needle. We have a metal notch. Put this metal notch inside the metal slot, and the wire also in this space, and try to grip or close the back handle, this one. So when you are closing the back handle, now the metal notch will go inside and everything will be attached together. So now you are attaching the pin with the needle, because you put the metal notch and you close the grip. This is the grip, and after that, now you are ready to design or to adjust the loop size. If you want to adjust the loop size, you have to cut first the protecting stopper. This is the rubber stopper to protect the loop from going inside the needle. So you have to cut it, and with your scissor try to cut the half of the stopper until you have this maybe view. Then you can remove the remaining rubber protector with the scissor, and then now you have the loop ready to be used. So now the loop is straight, and to manage broken files inside the root canal, we need a curved loop. So you can put the loop inside the calibrator and calibrate the size of the loop, because if you have a small broken file, you need a very small opening loop. You need a very small loop to catch it. Very big loop will not go inside the root canal. So you can calibrate the size of the loop also when you are trying to adjust your BTR. So as you can see here, according to the size of the broken file, you can see it clinically under microscope. You can determine the size of the broken file with your endoprobe. You can put your endoprobe on the coronal cross-section of the broken file, and according to the endoprobe, when it touches the broken file cross-section, you can have a slight image or a slight idea about the size of the broken file. And according to that, you can manage the loop size. Then, as I told you, I need to have a slightly curved loop to be able to put it inside the root canal and then catch it and pull it out. So we need a slight curved loop, and for such technique, you can just pull up your needle when you are using calibrator, or just simply put your loop on a table and do like that until you have a slight curve, or with your finger a little bit with your hands. You need this curve to be easier for you to be placed over the broken file. So now the BTR is ready. you adjust your loop size, you grip the metal notch with the needle by the grip knob, the back handle, and now you have to also adjust the slider. This is the slider. When you put your loop over the broken file, you have to pull the slider to close the loop. So this is the slider, but the problem is when you pull the slider to the end, the loop will go inside, and then you cannot put it again back. You cannot put it outside again. So you have also to adjust this one, the cap to block the slider. You can adjust the cap until you reach to the maximum closure for the loop without going inside the needle. I know it's a little bit difficult, so I will try to explain here in this video a little bit the setting of the BTR. It's difficult for the first time, but when you do it by yourself for the first time, the second time it will take about 10 seconds, no more. So this is the slider, as you can see here, and the slider cap to block the slider is here also. You can adjust the cap. You can see now the slider cannot go back. This is the grip knob to close the loop and to attach the metal notch to the BTR bin. Now this is the needle, and you can see the metal notch here. At the front area we have also the loop. This is the loop inside the needle. This is 0.3 needle, and the loop inside is 0.07. So it's very small. This is the metal notch, and this one is the rubber protection to prevent the loop from going inside while you are setting your BTR. So bring the metal notch and put it here inside, and then slide the loop to its space here. Close the needle firmly with the BTR. I will repeat again. Put the notch here, again put the loop in its place, and put again inside the needle. And now you can try the slider. Okay, it's working perfectly. You can push the slider inside, and the metal notch and the loop are going inside. This is the job of the rubber protection, to prevent the loop from going inside while you are trying to set the BTR. Here I will close the grip, so the metal notch will go inside. You see now the loop is closed, and the metal notch, this one, is going inside, so it's not visible again. So now I have the BTR bin and the needle as one piece connected together. After that I will go to cut my rubber protection that was placed to protect the loop where you are setting the BTR. Then, as you can see here now, as I will show you, you can set up the BTR loop with the calibrator. This is the calibrator, and according to your size of the needle, you can size of the broken file, you can calibrate this loop. So you can close a little bit. You close the grip. Now I am closing the grip, as I will show you. I am closing the grip, and when you close the grip, the loop will be smaller because the wire is going inside the needle. Look now, I will close the grip here, and I will put the loop on the calibrator, and it's closed. You see? Okay, I hope it's clear. Then I have to do the curvature I told you about. Just raise up your needle, and you will have a curvature here. Or just simply do it on the table, or just do, but I prefer this one because it gives you sharp curvature, as you will see now. It gives you a sharp degree, and it gives you a great degree of curvature to be easily. And as I told you, you can adjust the degree with your finger. Okay? So now we are ready. The loop is ready. The needle is ready. And the size of the loop is ready. And we have to go to the broken file to remove it. Let's go to the removal technique, step by step. First of all, the first step is to see the broken file. And to see the broken file, you have to use microscope. I am sorry to tell you that, but with loops, you cannot remove any broken file. With loops, you can only see the broken file at the orifice level, or maybe 0.5 millimeter down the orifice. No more, no less. And this is not my thoughts. It's studies published, and I will put the link for this study on the comments later when we finish. You cannot see with the loop inside the root canal, never ever, because you need a strong light, you need a high magnification, and you need for sure the beam of the light. That's why you have to see the instrument, and when you see the instrument, it's okay. You can use directly the ultrasonic, or if you cannot see it clearly, you can use Gates Glidden. But with Gates Glidden, don't cut it. Please, don't cut the Gates Glidden to do the platform. The platform, staging platform, is to cut the Gates Glidden and then to drill all the way until you reach the broken file. You are removing too much dentin. And we have a technique now, which is the loop technique, with a strong wire, to remove the broken file without removing too much dentin. So try not to remove, try it. Just give it a try. Try not to remove any dentin. Just enlarge the canal a little bit with the Gates Glidden, and don't do it directly. Just look inside the root canal, clean it, activate the irrigander, and check. If you cannot see the broken file, go and enlarge. And sometimes you need to enlarge only in one wall. Don't go with the Gates Glidden size 3 directly. Go with size 1. Enlarge a little bit, maybe on the inner wall, on the inner buccal wall, inner lingual wall, just to see the broken file. Don't cut the Gates Glidden, please. And then, when you see the broken file clearly, you can see the cross section. I don't recommend to drill until you see the full cross section of the broken file. Just if you can see 2/3 of the cross section, it's okay. Continue the remaining 1/3 with the ultrasonic tips. It will be more conservative. So continue with ultrasonic tips until you see completely the broken file clearly, and then go to the next step. The next step is to do the ultrasonic preparation around the broken file. We need to prepare at least 0.7 to 1 millimeter in depth. So this is the broken file, and I have to prepare in depth about 1 millimeter or 1.2, because if you will use the bigger size of the BTR, you need a little bit more depth. But if you are using the 0.3 needle size, which is the yellow one, you need only 0.7. So 0.7 to 1 millimeter in depth, and also I need to prepare in width. So the preparation in width will come easily because you are already preparing with the ultrasonic in depth, and the ultrasonic tip has a width, so it will prepare in the width also. But sometimes we need to enlarge this preparation in width to 1 millimeter. Why 0.7 to 1 and 1 millimeter in width? We will see later. The third step is to insert the loop. Now you have the BTR and the loop ready. You have to insert the loop over the broken file, and when you make sure that the loop is surrounding the broken file 100%, you can scroll again the slider to close the loop and go out. So now my loop is ready. You can see here, because the wire is strong, because it is nickel titanium nitinol wire, heat treated, I can push it a little bit. While if it was a stainless steel wire, it will be break off. So now the broken file, the loop is catching the broken file firmly, and I have to close the loop. You can see it's engaged, very well engaged, the broken file, and also it's leaned in a curved canal, and then pull it out. So you can remove broken files with a loop technique without making the files dancing, without making the files movement or moving. Why? Because the wire is strong. If you have a weak wire, it will be break off. This is the concept. This is the concept why we have to change our mind into the loop technique with a strong wire like PTR wire. So let's have a closer look here. We talked about the preparation in depth. So we have to prepare about 0.7 to 1 millimeter in depth, as you can see. And here we have the wire size, which is the 0.3 millimeter needle and the 0.078 the wire size. Why the depth? I will just do this one to explain for you better. Okay, here you can see my pointer. This is the depth of the preparation here, and this is the wire size. So I need to put the wire of the BTR a little bit down, so I need to prepare about 0.7, and the needle size is 0.3, so I need to prepare in width. So the width from here to here should be 1 millimeter here and 1 millimeter here, because I need to place the needle also behind the broken file. It's not enough to place only the loop. This needle should be placed, and that's why we have to prepare a little bit in the depth and also in the width. So if we assume that this is the broken file, this is the broken file cross section, and you are seeing it now clearly under microscope. So you need to prepare 1 millimeter all around, 1 millimeter on the buccal side, lingual side, mesial side, distal side, around the broken file, and then place the loop, close the loop, and pull it out side the canal. I will show you some clinical cases, and I hope that with the clinical videos, with the clinical pictures, you will catch the idea, or you will see the exact point that I was talking about. So let's see this broken file in the distal root canal of the upper molar. It's a long broken file exceeding the apex. It's stuck inside the root canal. So clinically I can see it directly because someone before me tried to enlarge the canal a little bit coronally, so I can see it directly. But I need now to put my loop. I need to put my loop over the broken file. So I need to prepare a little bit. And as you can see, I am now done with the preparation buccally and palatally. So the broken file is, if you assume that the broken file is in the middle area or the middle of the canal, you have to prepare buccal, palatal, mesial, and distal. So buccal and palatal now is ready, but mesial and distal still the broken file is touching the walls. So the loop will not sit there. The loop will not be holding the broken file because we have to provide a space for the loop. So I need to enlarge a little bit my preparation mesially and distally until I reach to this view. Now you can see all the walls around the broken file prepared, and we can then place our loop. So broken file now is not dancing, it's just prepared coronally, and you can see I am inserting the loop, closing the loop, and then pull it out just in maybe 3 to 5 seconds. Take your time with the preparation with ultrasonic because it's the key, and then place the loop, and in 3 seconds you can remove it. But make sure that the loop is engaging the broken file firmly, and then close it with the slider and go out. So another case. Still this one. Okay, here is the X-ray after removal. You can see the amount of dentine removed is at its minimum, as minimum as we can, because the case was they tried to remove the file previously and they enlarged a little bit more. So another case, if we have this broken file in this premolar and we want to remove it. It is stuck a little bit with the walls, and we want to remove it with the grasping technique. So we have to use tube technique. So I need to drill all the way from here till we reach here. I need to enlarge all the dentine area here. I hope that you can see now my pointer. Okay, so I need to try to drill all the way here until I expose 1 to 2 millimeter from the broken file, and then you can catch it with the tube technique. But if you can see clinically, I can see the broken file here clearly, and I have a space. I have already a space here. So no need to drill all the dentine here. No need to drill everything. No need to use ultrasonic because I have a space. And my wire size is 0.07. So it's very thin. So let's try to put it around the broken file and remove it. Let's try. Don't go directly to the last choice you have. Don't go directly to remove dentine. Try first to remove as conservatively as possible. And as you can see now, the loop is big. I will try to close the grip a little bit to reduce or to decrease the size of the loop, make it smaller. And now, because of its thanks for its flexibility, it's nickel titanium, you can see that I can squeeze it on the wall and I can insert it and push it inside, and now the broken file is out. Why? Because I squeezed the loop buccally, palatally, and because it's nickel titanium, as I said, it goes down, so it engages the broken file. I closed and I go out. It takes only, the whole procedure takes only maybe 2 to 3 minutes. Very nice. And if you see the X-ray after we remove the broken file, you cannot see that there was a broken file here, because our problem is when we remove the broken file and we do the obturation, we feel that we destroyed the root. And now if you see the post-op, you cannot notice that there was a broken file here at all. So as conservative as possible, yes, as conservative as possible. Okay, another case. I will show you different cases, different situations to see the ability of this technique and this instrument. I have a case here with the broken file in the palatal canal, and we have a screw and we have a final filling, so we removed everything, and then we saw the broken file without removing any dentine. This is the broken file. When I removed the screw, directly I checked inside, I saw the broken file. So no need to enlarge more this area from here till we reach the broken file. No need. Directly I saw the broken file because the previous dentist already enlarged the canal and put a post there. So it's already enlarged. So don't try to enlarge more before you check under microscope. Then with ultrasonic tips, now you can see I am preparing palatally, then mesially, distally, and then buccally. You can see mesial, distal, buccal, just a little bit, just 1 millimeter in depth. Don't forget, don't go too much inside. You will remove more dentine. Stay conservative, and you will be able to put your loop and you will be able to pull it out. So just a little bit here on the mesial side, then buccal side. I am just ensure that there is enough space for my loop. Then I will try to calibrate the loop size, and you can see here the loop. I am going inside. Again, I can push it inside a little bit, and now it engaged the broken file. Then close. Okay, go out. That's it. So broken file removed. It was stuck and it was not dancing, and despite of that we have removed it with a loop technique, and we have more conservative removal for the broken file. Here is the post-op X-ray, and you can see the X-ray of the removal. There is no sacrificing for the dentine. There is no any dentine sacrifice. And we put again fiber post, and we did the build up. Okay, another case, different situation. This was H file, firmly engaged, and it was broken in a C-shaped canal. So we have isthmus here between the 3 root canals. I can show it to you now clinically. And this broken file was engaged. I tried to bypass. I couldn't bypass. So I have to remove. So after the preparation with ultrasonics, I exposed 1 millimeter only of the broken file. Then I have calibrated my loop size, very small one, because this is very small broken file. It's not a rotary file. When you put your loop, and when you are 100% sure that your loop is surrounding the broken file, you can now scroll and close the loop. Then try to pull out. Look at the resistance I have. It is stuck inside. It's fully engaged. And now I am trying to pull it out 1, 2, 3 times. It cannot move. It doesn't move. 1, 3, 4, 5. Come on. Up. Yes. Now it's out. You see? You see the resistance? We have very high resistance to remove it. And despite of that, the loop is not broken, and also the broken file is removed. If we want to remove it with ultrasonic, I have to go deep, deep, deep to disengage it from all the surrounding walls. If I have to remove it with the tube technique, I have to drill all the way until I reach there. But you can see the post-op, and you can see also the removed, sorry, let me drink some water. You can see also the removal x-ray, minimum dentine sacrifice. Okay, another case. We have a broken file in this upper lateral incisor. This broken file is, I think, S2 protaper, and it's fully engaged here. If I want to remove again with the tube technique, I have to remove all dentine here to do the triffin around and then catch it with the tube and go out. Let's see how we could remove it, or we can remove it with only BTR technique. Now the ultrasonic tips is working. You see it's fully engaged. I have no space to put my ultrasonic, but I will try to drill around the broken file and expose at least 0.7 millimeter in depth and 1 millimeter in width. The 1 millimeter in width, we will gain this 1 millimeter because we are already preparing in width, in depth. After that, put your loop and make sure with high magnification. You can put your loop and increase the magnification of the microscope to check that the loop is fully engaging the broken file. And when it's fully engaging the broken file, you can now close it and try to go out. Sometimes you will feel some resistance because the broken file is fully engaged. Look at this. I cannot remove it. It's fully engaged, but you have to pull. And don't be afraid. Pull out strongly. Yes. It will be removed because the loop or the wire is effective. The wire is effective. I catched only, as you can see here, only 0.7 millimeter to 1 millimeter, and we can remove it because again and again the wire is the key. We have to use strong wires. You can see here the removal x-ray, and you can see the obturation x-ray. You couldn't notice that there was a broken file here. So conservative, yes, conservative, but we have to apply the steps. We have to apply the step-by-step removal technique by BTR. Another case, maybe I showed you this one at the beginning, and this one also was removed with BTR. In this case, I didn't do any pre-flaring. I didn't also use the Getzigliden because the canal is already wide. Just I put my microscope, I go inside, I saw many debris, gataperca from the old treatment. I activate the irrigant there and then dry the canal with the microsuction or with paper point, and then I saw that the broken file is visible. The cross section is visible. So I go inside with the BTR, hold it, pull it out, and that's it. Complete your root canal treatment and done. So I think the idea is clear. I invite you all to read the chapter in our retreatments book, the book that is powered by Style Italiano Endodontics, with the editors Paolo Bertani, Massimo Galliani, Fabio, and the authors with all the chapters. Also, it's my pleasure and honor to be a co-author in the chapter of the broken files with many friends and colleagues from Style Italiano Endodontics group, and from also outside Style Italiano. We have Yushi, we have many great co-authors. So I invite you all to try to see this interesting book. I think I am done. Yes, this is the final slide, and thanks you for your attention. I am very happy that you are still live with me. Thank you very much. It's my pleasure to be here with Eti. Thank you very much, Ivy, Lily, all of you. Thanks for all the attendees. And now I am ready for your questions. If you would like to ask any questions, just please, Ivy, if you can send me the questions. I am available. Okay. Any questions, guys? Can we discuss a question? Okay. Okay. Okay, Ivy. Can you send me the questions, please? But choose easy questions. Choose easy questions. Okay. Okay, no problem. I am waiting, Ivy. Just please check the questions. Send me on Messenger or WhatsApp. Okay. How many questions? Wow. 25. Okay, I will try to reply as much as I can. Mark Kalustian, how is it is possible to bypass without canal transportation? Yes, Mark. It's very difficult to bypass, and it's very difficult to know that we are staying in our normal or in our real anatomy. That's why I don't suggest to go beyond 20K file, manual K file. If we have 15, maybe loose, very loose, we can go with small rotaries, taper 2 or taper 3. And if not, if it doesn't go inside, we can go to 20K file. But we have to try to be to minimize the use of the manual K files as much as we can, because we can transport the canal for sure. We have another question from Wiria Khoshnawa. Okay, Khoshnaw. Okay. What if the file separated just at the apex? What if the file separated just at the apex, full working length? I mean distance of file and AF is 0. If I understand your question correctly, you mean that you have a broken file at the apex, full working length. I mean distance. If you mean that the broken file is separated from its coronal part, so all the 16 millimeters is separated to the full working length, for sure we have to remove it. Like for example, the lateral incisor I showed to you. But if you mean that you have a broken file at the apex, as usual, we have to bypass again. We have to try to bypass, and if not possible, we have to remove for sure. If we have a joint canal and you can bypass the broken file from another canal, it's very good. Why not? Abdurrahman Adil, yes, but kind file don't weak a file or increase possibility of broken files. I didn't understand exactly your question. Sorry. Can you send again, Abdurrahman Adil? Zaid Husseini, what about the use of dfinder and C files to catch for the bypass? Yes, you can use the dfinder, you can use C files, but in my opinion, if you use or if you used any kind of files or all kind of files and you couldn't catch a space, you will not catch. So after 10-15 minutes, please stop trying bypassing, because after that you are deviating the canal. If you have a catch, you will catch this tiny space after 5 minutes, 10 minutes maximum. If you don't have a catch, then after 15, 20 minutes, you are pushing your files again, your D files, your C files, then you are deviating and you are doing your own canal. And this is very dangerous. Mahmoud Shurab, okay, do you recommend to use reciprocating handpiece? Actually, no. For bypassing, actually, I don't recommend. Keep it manual and keep your sensation in your fingers. Muhammad Ahmad Al-Ghawi, while doing watch winding movement, you use EDTA or not? Yes, while doing, when you have the catch, don't use EDTA before catching a space. When you have the catch and you feel that you are proceeding apically, you can irrigate, you can use EDTA gel, and you can go back to this catch and try to enlarge the space more and more and more. But before catching a space, don't use EDTA because it will facilitate the maybe the manual file to go and to perforate your root. Mark Christian again, very active Mark, my friend. Push pull with brushing. Yes, you mean the bypass movement. Yes, push pull with brushing. Yes, but as I said, after watch winding motion, after catching the space, watch winding motion up, watch winding motion up. Then stay there and do some in and out motion with this movement I explained in the video. I don't know what to name it. Sarah Dent, before beginning the procedure of the treatment, how can we guess the difficulty of the case from the visualization of radiograph of the broken file? Before beginning the procedure, yes, you can guess the difficulty of the case if you see that the broken file is inside the curve, if you see that the broken file is in the middle to the apical area. You can also take a CBCT. Take a CBCT because sometimes we have internal anatomy and we have broken files inside this anatomy, maybe buccal lingual or mesial distal, but it's not obvious on 2D X-ray. You can see that I said that in the beginning of this lecture. You can see that the root is not severely curved, but the anatomy inside is curved, and the broken file is located there. So you can take a cone beam to be sure 100%. Amir Habib, as your choice of selection is stiffer file like C+, do you think the stiffer file have more chance of fracture? I think no, because it is stiffer. But as if you saw the video again, I started with normal K file, not with C files. I started with normal files. I have to check that the normal file with the non-active tip is catching a space, and then after catching the space and try to negotiate around the broken file, then I move to the C file, which has active tip, and to go inside this catch and try to drill again or to negotiate again. Okay. Mark Calustian again. Do you use only 10K file or sometimes 8K files? Yes. Thank you for your great question, Mark. I forget maybe to say that sometimes I need 8K file, but 06 or 6K files are not used in bypass, in my opinion, because they are very small, and whenever you touch the broken file or you touch the wall, directly it bends and you have to discard it. So 8K files, sometimes yes, but our golden weapon is the 10K file. Deepika Karaneth, okay, Deepika. How do you know that you are still in the canal when your file starts going towards achieving the working length? It could still be a perforation or ledge. Yes, that's why I told you, if you tried for more than 10 to 15 minutes and you couldn't have a catch to bypass a broken file, please stop and don't try again, because after that you are maybe destroying another area and you are trying just to push with your C files, stiff files with active tip, and then you are drilling or doing ledge, or then after the ledge perforation. So Patel, a question from Nashikit Patel. If we don't get purchase point, then what to do? If we don't get purchase point. Then what to do? I didn't understand the question correctly. Please send again. Raymond Tawfiq, what is the type of the K file of 10? Normal K file. Stainless steel, normal K file. Flexible or night-eye, normal stainless steel K file. Then you can use the C files. Haidar Ashimari, what about apical tuckback in the bypassed canal? Yes, sometimes we are facing these difficulties to obtain a strong tuckback when you are bypassing a broken file. Then you shape with the rotary files, but because of the broken file and the shaping was difficult, so I cannot go for bigger sizes to obtain a bigger tuckback or a stronger tuckback. So with the X-ray, if you feel that you have patency, and with the X-ray you feel that you can see clearly that your cone is fitting on the working length and you have patency, so you can obturate safely. Then I have a question from Dr. Haidar Walid. While bypassing, the irrigant is sodium hypochlorite? Yes, the irrigant is sodium hypochlorite only, and sometimes I use EDTA gel, no problem. Iman Baghdadi, please I need explain the rotary for root canal treatment. Okay, we will explain that maybe later or in the comments. I will reply for your question, but today we are talking about broken files. Saeed Farouk Forka, okay, is there any special protocol for bypassing for the case where the separation took place in the beginning of preparation of narrow canals? The situation is difficult because it's already a narrow canal, and now we have a broken file and narrow canal. So in narrow canals, and if you are at the beginning of the shaping or the negotiation, maybe it will be broken in the middle third or coronal to middle third, which is more easier. But again, you have to bypass. If not, you have to go again to removal. Okay, I have another question. During bypass, need EDTA? During bypass, you can use EDTA gel, as I said, already answered, but not as the first K file is negotiating the broken file or the space. Don't use EDTA. Okay, when you have a catch and then when you do the watch winding and you feel that you bypassed already, and you take X-ray and your working length is reached and your K file is reaching the working length, then you can use EDTA to facilitate your 15 and 20K files. Would you please repeat the name of the irrigant method? Irrigation method. I didn't speak about irrigation, but usually sodium hypochlorite. If you mean during the bypassing, sodium hypochlorite, no more, no less. Should we change torque during rotary files? Not necessary. Keep as you wish your torque and your speed according to the manufacturer. Sarah Dent again, how to assess possibility of retrieve or bypass? How to assess the possibility? Maybe I have to say again that according to your initial X-ray, you can assess the possibility when the broken file is located in the coronal or middle third, when the broken file is big, when the broken file is long. This could lead us to more remove the broken file. While if the broken file was, maybe now you can see me better. Okay. When the broken file is small or short or 1, 2, 3 millimeters, so we go to bypassing choice. The one gun, can we use M4 reciprocating hand beams? I don't suggest that. Keep it manual and keep it with your sensation. I think we have so many questions. Can I use loop? Noor Karim, can I use loop instead of microscope in the case? No, you can't use the loop because you cannot see the broken file correctly. How to bypass a large H file? Large H file could be bypassed, but it's difficult than normal K file or normal file. It's because the H file will be fully engaging the root canal, and there will be no any space. So with large H file, I don't try to bypass because I know that I will not be able to bypass it. I go directly to the removal. Dr. Iyad Tajuddin, if the broken file was small and at the apex, can we leave it? Sometimes yes, we can leave it if we didn't, if we are not able to bypass it, and if the broken file was at the last stages of the cleaning, maybe after you clean the root canal and you shape till 25, for example, or 4 or 25 or 6, then the last 1 millimeter of the rotary file is broken, and you couldn't bypass. So you can, yes, you can keep it and you can obturate, because the third management, I said in the presentation, the third management is to obturate and see, and after that you can decide. If you have any problem or periapical pathology, we can go again to removal, or we can go for surgery. I think I will have only 2 to 3 questions because we have to end the streaming. We have Fabio now after this presentation also, so I don't want to take all the time. If the file is broken beyond the curve, how can I manage? Does the BTR is flexible? No. If you have a file beyond the curve, you will not be able to see it. And if you cannot see it, you cannot use the BTR, or you cannot remove it. So try to bypass, and if not, so then we have to go to another choice. Maybe we have to remove too much dentine from the inner wall to enable us to see the broken file, or we can go for surgery. The last question, let me check. Amer Mukhalalati. Welcome, Amer. Before starting to bypass, to what size do you prepare your canal down to the file? Before starting to bypass, to what size do you prepare your canal down to the file? Sometimes you can see that the canal is already prepared or already wide in the coronal part. But I don't recommend to prepare too much, because if I need the 10K file to go down and to be engaged with the canal walls and to start only working on the first 2 millimeters. While if it's free on the coronal area, and it will be very difficult to have a catch. So maybe I don't recommend to enlarge too much coronally. Keep it as much as you can small and try to find a catch. Then you will prepare the canal. Now Ivy is telling me that Fabio course will be the next week. Okay, so we can proceed with the questions. Okay. Queen Ling, will the end of the broken file break while you pull the file out using PTR pen? No, it will not be break, because you are engaging it with the loop, and with loop you can pull it out altogether, because the loop is not stronger than the file, so the loop will not break the file. Maybe the opposite, sometimes yes, this loop sometimes we can break it. So in the opposite, no, we cannot break the file by the loop. Want the broken NiTi file move toward the outer curve, thereby reducing the space for the loop? Very interesting question. Thank you very much. When the broken file is nickel titanium, you always go inside, and you find that it's leaning on the outer wall. That's why we have to prepare a little bit from here with our ultrasonic on the outer wall to enable us to put the loop and then pull it out. Yes, I agree with you. If you couldn't catch the broken file and you pull the loop inside the needle, do you have to put another loop? Yes. If you couldn't bypass, if you couldn't catch the broken file and then you pull it inside, you have to use another needle. But you can prevent this situation by blocking the slider. So try to pull the slider until you see the loop is reaching to the end, and before going inside the needle, put the cap for sliding blocker. So you block the slider, so if you pull to the maximum, it will not go out, it will not go in. I hope it's clear. You can prevent the situation by the cap slider blocker. So you can block the slider by the cap. That's why we can prevent the loop from going inside. And if you block the slider, it will reach to the point or the area of the tip of the needle. Then you can, with the tweezer, bring it out to use it again. Some devices, some loop devices, you couldn't change the loop. You have to discard all the device. We can have the idea of small size of the broken file segment from the rest of the segment of file. Joao Ricardo, how deep you need to remove around the file fragment to insert the BTR bend? I already explained that. 0.7 to 1 millimeter in depth and about 1 millimeter in width. Diana Abdul Jawad, ultrasonic setting when troughing around broken file and with water or not? No, without water, just dry to enable you to see clearly around the broken file, just dry. And at what setting? Usually I use external ultrasonic device and I put it on 3 to 4 power setting. 3 to 4 power setting. It's different devices. Each device has a different amplitude. So my device on 2 to 3 or 3 to 4 is perfect. When we are using only the ultrasonics for removing broken file? Yes, Mahmoud Shurab, I think I have answered this question. Ghais Adnan, is BTR broke if push and pull hardly? Yes, it can be broken. We can break the BTR loop, but a little bit difficult. Not an easy job to break the loop because the wire is strong. But sometimes, yes, I broke many loops, many BTR loops, no problem. Sometimes it's broke. What if the broken file is just 1 millimeter from K10 file? What is the broken file is only 1 millimeter of 10K file? Yes, it will be easier to bypass because it's very small broken file. It's not engaging all the root canal, and it will be more easy to bypass it. Okay, Hala Alwan. If we have more than one fractured instrument at the same time or the same spot, will you intervene in the same way? If we have more than one fractured instrument inside the canal, in my opinion, it's easier to remove than to bypass because the first one broken inside is the hardest one, but the second one or the third one or the fourth one, they are all together like that. So when you remove the first one, the second and the third will go out because we have enough space, while the first one is the most difficult one. So in my opinion, when I see 2 or 3 broken, I have many cases, but I forgot to put in the presentation. When you see that you have 2 or 3 broken files together, it will be very easier to remove it rather than bypass because the space is fully occupied by broken files. And with ultrasonic, just 2 to 3 strokes around the inner wall, you will see that they are going outside. Okay. Hadi Nasser. Hi, my friend Hadi. By retreatment, if the broken file is partly surrounded by gutta percha, what is your suggestion to remove the gutta percha effectively without damaging the root or create false path? Okay, if the broken file is partly surrounded by gutta percha. So if you are going to do the retreatment and during the retreatment you break a file, if I understand the question correctly, so now you have a broken file and a gutta percha around the broken file. In such cases, it's very easy because the broken file is stuck inside the gutta percha. and it's a great chance for us to remove it with ultrasonics, because we can activate our ultrasonic tip in the getaperca and it will be go out. But sometimes you have to prepare a little bit, and sometimes you have to use solvent. In such situations, you can use getaperca solvent and activate the solvent there in the inner wall, so you will dissolve the getaperca and then again activate, and I think it will be removed. Muhammad Ismail, when you want to remove broken file from mesiobuccal canal in upper premolar using ultrasonic tips, you did say we have to remove dentine from the inner side of the canal. Did you mean to remove dentine buccally or palatally? Very nice question. Thank you very much. Always, when we are determining the inner wall, we have to use the cone beam to know exactly which one is the inner wall or which wall is considered the inner one. But for example, if we are dealing with the broken file in single root or two roots or two rooted premolars, for example, and you have a broken file in the palatal canal, you have to think a little bit physically. It's about physics. If you are going to put it on the buccal wall, to put the ultrasonic there and try to activate there and drill there, then the broken file will be more harder to go out. But if you are putting your ultrasonic tips on the palatal area or palatal side, which means inner wall, that means that you have easier chance to bring the file out. So it depends on the situation, and it depends on the internal anatomy, because we cannot be sure 100% if this is the inner wall or not. Dr. Mazen Dumani, my friend, is there a probability for nitai wire to be cut? How much? Yes, there is a probability to cut the nitinol wire, but actually I don't have a correct number or correct examination or correct test. We are trying to do many tests to test maybe more than one wire and more than one device in the market, but still we have to see the results, and for sure I will keep you updated. Yasser Twejri, welcome my friend. How can use BTR if have curvature canal or a curved canal, or leave it? The book of retreatment, from where can I get? The book of retreatment still will be available soon in the market, as I know. But for the first question, if you have a broken file in the curved canal, you can try to bypass it. And if you couldn't bypass, then we have to remove. And if you couldn't bypass from another canal that may be joined with this one, we have to remove. Or maybe if we want to remove and then we will destroy the root, it's better not to remove. Maybe we have to obturate to the level of the broken file and then keep it under observation. Don't forget that we have a last chance, which is the periapical surgery. Milan Radosavljevic. Okay. Do you use most of the time yellow BTR needle? When would you use larger one? Yes. 90% of my cases are done with the yellow one, but sometimes I use the bigger one for bigger mass or for bigger broken files. For example, if you have F5 or F4 ProTaper file and broken at the D16, so you need something strong to catch and pull it out. So sometimes we have to use the 0.4 or 0.5 needles. Again, Yasser Abu Omar, power setting for ultrasonic, which power do you use? 8 teeth have 2 power setting, which one prefer? Okay, for ultrasonic tips, I use external ultrasonic device. I put the setting on 2, 3, or sometimes on 4. With the 8 teeth Ultra X, very useful device, very nice device, you can put on the second one, which is the more powerful one, because the first one, the amplitude is very low, so we need something a little bit stronger. Just 1 minute, let me put the laptop with the charger, because I think I will lose the battery. Okay, I think I will have to take the last two questions. Won't the broken NiTi file move toward the outer curve? Yes, we answered already this one. Omar Shafi'i, doctor, if you couldn't catch the broken file and you pull the loop inside the needle, do you have to put another one? Yes, we answered already this one. Muhammad Zahar, yes, hi Dr. Muhammad. Type of ultrasonic device and tips used. Sometimes I use Ultra X, sometimes for a little bit preparation on the canal wall. Sometimes I use Yushi tips, sometimes ET25 tips, sometimes ED6. It's according to the case, to the situation, but they are all effective. Okay, the last question, Zakaria Harun. If the case is referred to you, how you know the diameter of the broken file to calibrate the loop? Very nice question, and I have answered this question during the presentation. We can know the diameter or the size of the broken file by placing the endoprobe. When you place the endoprobe over the cross section, this is the cross section, and you place the endoprobe here. If you have the same maybe the diameter, so you can now transfer this diameter to the loop. With the endoprobe, with the DG16, you can place it inside and then transfer it to the loop and close the loop on this size of the endoprobe. So with endoprobe and then transfer it. Khalid Al-Aini. Hi, my friend Khalid. How can I know the truly size of the broken file? I have answered this now. Thank you very much. مؤيد الطويل. The file fragment should be free from catch coronally to engage the loop. Yes, should be free only in the first 1 to 2 millimeters. Only. And 2 millimeters is too much. That's just 0.7 to 1 millimeter. Ahmad Al-Karim, are you doing this case always with the microscope, and can we do it without? No. It should be done under microscope. To see the details we are talking about, the 0.57 to 1, the 1 millimeter around, you have to use the microscope. Ubada Halak, in bypass cases, how to avoid the fall of the fragment apically after or during enlargement of the file canal. Actually, we cannot prevent the falling of the broken file apically. Sometimes we bypass, we complete our bypassing, and then when you are doing the last shaping file or the final shaping file, you can see that or you notice that the broken file now is more deeper and blocking the root canal. So we cannot expect that. Try as much as you can to recapitulate with your manual files. Okay, I think I have answered most of the questions. I will answer the remaining questions on the comments. Thank you very much for attending. Thank you all. Sorry for the delay again. Thank you, Ivy. Thank you, Lily. Thank you, Mickey. Thank you, Elfie. All AT team. I hope you enjoyed my presentation. Thank you very much and bye-bye.